can be seated. I hope you had a wonderful break, ladies and gentlemen. Doctor, will you please raise your right hand? Do you solemnly swear to tell the truth, the whole truth, and nothing but the truth, so help you God?
I do.
Okay, go ahead and make a seat there. You got an aerial mic there in front of you.
Okay.
So I need you to state your name and then spell your name for the record.
Sure. It's Gina, Gina, Moody, Moody.
Okay, and for health reasons, you would prefer to leave your mask on. Is
Yes,
that correct?
please. Thank you.
Okay, well, I understand, they have to hear you.
Sure.
So it's a give and take. You got to put some volume out.
Okay, I'll do my best. Let me know if I'm not.
You guys hear her okay?
Thank you.
May I proceed, Ms. Wheeler?
Thank you, Your Honor.
She didn't hear her first.
Oh, can you say your first name one more time for me, Dr. Moody?
Sure. Gina, Gina.
Good morning, Dr. Moody. So, first of all, where are you currently employed?
With Mount Carmel Medical Group.
And where, which facility?
I work at Mount Carmel Grove City and Mount Carmel St. Anne's
And in what capacity?
as a pulmonary and critical care physician.
Okay. Do you work specific hours?
I work during the day. We work in different capacities. We see all of the patients in the ICU, as well as patients admitted to the other parts of the hospital with lung disease, and have an outpatient practice at both of those locations where we see pulmonary patients on the outpatient side.
Okay. And why don't you tell me a little bit about your education, how you got where you are?
Sure. Went undergrad at Notre Dame 4 years, and then medical school at Lake Erie College of Osteopathic Medicine. I did my residency at Riverside Methodist Hospital here in Columbus in internal medicine for 3 years, and then pulmonary and critical care fellowship, which I completed at St. Louis University in 2013.
And could you explain for the members of the jury what a pulmonologist is, what they do?
Sure. And as I said, it's pulmonary and critical care is my background. So we do a 3-year fellowship, training in both of those specialties. Pulmonary is treating diseases of the lungs. So really any disease that afflicts the lungs, we will see patients. The most common things being asthma and COPD. And the critical care portion is the management of patients when they're in the intensive care unit.
So those two combined together in your practice?
Correct. It's a joint specialty.
Okay. And are you licensed and boarded in both of those?
That's right, yes.
How long have you been?
I would have taken, internal medicine boards I would have taken in 2009, pulmonary in 2012, and critical care in 2014.
Okay. And do you have any continuing education requirements to maintain your licensure?
You do. There's, to maintain your state license, you have to maintain, I don't know the specific number of hours that are required, but that's dictated to us.
And have you maintained all of your credentials since 2009, 2012, and 2014?
I have.
And how did you come to work for Mount Carmel?
Upon completing my fellowship, I was looking for jobs and interviewed and had a desire to be back in Columbus, having done my residency here. And so I interviewed with the group. At the time, it was a private practice group, not employed by Mount Carmel, called Central Ohio Pulmonary Disease. And interviewed with them and liked the practice quite a lot and the other physicians. And so I joined them in August of 2013.
And now, specifically within the ICU, what is your role?
I function as an attending physician, so we see all of the patients for whom there's critical care needs, and basically manage their day-to-day care throughout their ICU stay.
Could you be more specific when you say manage their day-to-day care?
We're ultimately managing those patients. So for instance, in a patient who is on a ventilator, we're managing the ventilator, making changes to that, trying to determine if they're ready to start weaning from the ventilator, managing any underlying diseases associated with their lungs. Patients in the ICU are often on vasopressors, which are medications to help their blood pressure, so we're frequently adjusting those. Other common things, frequently patients have infections and are septic or in septic shock in the ICU, so antibiotics, managing those. We often are doing this in consultation with other physicians. For instance, if a patient has kidney failure, our nephrologist are involved, and different things like that. But we're ultimately kind of coordinating the care of that patient in the ICU.
At any point, do you interact with family members?
Sure, on an almost daily basis.
Okay, what are those interactions like, or what's the purpose of those interactions?
First, just to keep the family informed that this person is critically ill. In general, that's a very tense, upsetting situation for any family, and very frightening. And then also, it's really important because often these patients are incapacitated, meaning they're on a ventilator or they're deeply sedated, so they cannot make decisions or advocate for themselves. So their family is who we turn to first to convey information, and then for them to tell us about the patient and provide background, and ultimately, in some cases, to have to make decisions as things progress.
How much of your time do you think you spend speaking with family members in the ICU?
Counselor, you're going to have to get your voice up.
Sorry. How much time do you spend speaking with families in the ICU?
You know, it varies day to day. If a patient is stable or getting better, it may be a brief 5 minutes. You know, they're doing pretty good today, that's it. Other times, if we have a lot more to get into or there have been changes in the patient's condition, it may be a 20 or 25-minute conversation.
And so do you create these plans with the family members involved?
We update them. I mean, ultimately, the plans, it's ultimately as the attending physician, my decision, and we have rounds every day with our ICU team. But we inform the family of all those plans, and as decisions need to be made, not just end-of-life decisions. If there's a surgery or a need for a procedure that requires consent, we're in touch with the family. So there's certainly a part of everything we're doing, but we ultimately are going to care for that patient. And there are cases where, unfortunately, there may not be family or, family present. We're still always going to act on the best interest of the patient.
And what happens at the end of your shift?
And again, we don't really work shift work. We have an outpatient practice. We're seeing patients throughout the hospital on given days. But at the conclusion of an ICU day at Mount Carmel Grove City, because we have residents, they sign out to the nighttime physician who is coming on at 7 p.m.
And between 2015 and 2019, were you working at Mount Carmel West in the same capacity?
Yes.
Was it the same procedure at that time?
Yes.
So you would transfer the care of the patient to the evening doctor?
Correct.
Okay. What are the expectations then at that point?
And again, this was resident-driven because we're a teaching hospital, but the expectation was essentially I don't want to say real, but it's certainly a pretty in-depth sign-off. They would go room to room, the senior resident and the nighttime physician, and provide a sign-out on this is what's going on with this patient, if there were pending tests that they needed to follow up on, that type of thing. And then similarly at 7 a.m., they would have sign-out rounds in a similar manner.
Okay. Have you ever worked in the ICU in the evening?
Yes, I would pick up some shifts there.
I'm sorry, one more time?
I would pick up some shifts covering the ICU at night.
Okay.
And sometimes I was just there late by the nature of the day.
How do things differ in the ICU in the daytime and in the evening?
I mean, in a number of ways. I guess first is you have a smaller team. During the day, you have multiple attendings in the hospital as well as residents and nurse practitioners. We have critical care nurse practitioners involved. At night, I think until about 2017, we had a nighttime ICU physician and a senior resident. And then somewhere around 2016 or 17, they pulled that resident. So he or she wasn't there anymore. So you certainly had less support from a provider standpoint. But the nights are different in that you aren't having to write a progress note on every patient or talk to every family. You're there to admit new patients to the ICU and stabilize anybody that becomes unstable or has a change in their condition.
So you said, no, you're not writing as many progress notes, you said?
Correct. During the day, every patient I see, make it 16 ICU patients, I have to write a progress note on, or if they're a new patient, a new consultation. At night, the only notes, not only, but the notes that the nighttime physician does are just on the patients that are coming in, or they would leave a brief note if there's a change in a patient's condition.
So generally, do you not expect there to be much in the medical record from the evening into the next day?
Again, it depends. If the patient is stable overnight, no, there really wouldn't be need to have anything from that physician. And if there's a change in the condition, typically a brief note to document what changed and what that physician did about it is indicated.
Okay. And in your practice, do you perform palliative care of any kind?
We do. Palliative ventilator withdrawals and even transitioning patients to palliative care measures is fairly frequent occurrence.
Can you talk to me a little bit about the transferring to palliative care, what that entails?
Sure, and it usually happens in stepwise fashion over typically several days. Somebody has been in the ICU, critically ill, without showing signs of recovery, and perhaps progressing. In some cases, it may be briefer if their condition is declining very rapidly. And it most often involves meeting with the patient's family to talk about what the wishes would be of their loved one if they could sit up and tell us that. And we'll often say that to families, if you can tell me what your loved one would want here. And based on those wishes and the patient's condition, we talk about making decisions, such as not resuscitating the patient should their heart stop. That's something we call a DNR-CCA, meaning we continue life support, but if the patient's heart stops, we would not resuscitate them, and we would allow them to pass away naturally. If the patient is continuing to decline or the prognosis is felt to be terminal, then we have those discussions and talk about transitioning the patient to what we call DNR-CC, which is a do not resuscitate comfort care, where we would withdraw the life support measures and subsequently allow the patient to pass away without, any interventions.
And when do you generally have these conversations with family members?
At any time, frankly, because a patient's condition can change. It's a very fluid situation in the ICU. I would say most common is typically in the morning we round on patients, recognize what's going on. It's typically in the afternoon that I'm meeting with families and having those discussions and making those decisions as needed. And do you perform palliative extubations as part of this process? Yes, we do. I do.
And back in 2015, 2019, were all these processes the same that you're speaking? Would you go through these same processes as well?
Yes, yeah.
Okay. Has your practice changed at all since that time when it comes to palliative care or palliative extubation?
I don't think in any significant way, no.
Okay. So can you talk to me in detail more about what you say to these families, what you discuss with them when you're discussing palliative extubations?
Sure. First, we'll review the clinical case, so what has gone on, and what's the current status of the patient. This often entails going almost, we'll say, organ system by organ system, meaning the patient has had a brain injury or perhaps, damage to their heart or kidneys, and sort of review the current situation of where we are. And often the fact that a lot of these things may not be reversible. We always want to fix the fixable problems, and if we're in a situation where we don't have fixable problems, then it's more dire, and we'll simply go through that with the family in detail and answer their questions, because it can be a bit overwhelming at times. And then, again, talk about what their family member, their loved one would want under these circumstances.
Do you prepare the family members for the actual procedure?
I do. Typically, we sort of introduce that as we start to meet with them, and then closer to the time, if we are going to be performing that withdrawal, we go into greater detail about what that will entail.
Is the extubation process a planned procedure?
Oh, yes.
And can you tell me maybe some specific things that you tell the family members? Do you prepare them?
Sure. We'll tell them, and we always give the family a choice if they want to be in the room or not, because the whole situation is very sad and it can be upsetting. And I'll typically tell them, and it's very individualized, frankly, but based on how the patient has been responding or not, we'll talk about medications that we may give prior to removal of the endotracheal tube. And I'll let them know that when the tube comes out, patients often cough and there will be some phlegm, and that while it may be distressing to them to see that, that is not inherently painful to the patient. But some families choose to step out during that part of the process. And then I make them aware of the fact that based on how that patient responds in the seconds, minutes, hours that follow, medications will be available to ensure that that patient is comfortable and peaceful.
Do you tell them what medications are available?
I don't know that I specifically do. If they ask, I certainly would.
Okay. And what medications do you use to keep them comfortable?
In my practice, most commonly are morphine and Ativan.
So you commonly use morphine and Ativan combined?
Or sort of alternating, and again, it depends on the patient's needs and the symptoms they exhibit, but those orders are in on an as-needed basis, yes.
Can you take me kind of step by step how you would actually do this process?
Sure. So typically, well, the first step is looking at what medications they are on, that they've been on sedative-wise. For instance, if a patient is on what we call a paralytic medication, we can't really do anything until that paralytic has been turned off. That is keeping them from moving at all. So we turn that off, and we monitor something called a train of 4 to make sure that that paralytic is no longer in their system. Once we are...
Doc, help me out. You're going a little fast there.
I apologize.
Okay? And
Yeah.
your poor hands are falling off as they're writing down.
I will
so-
slow down. Yeah, talking shop, so it comes natural. But I will, at that point, look at the other medications that they are on for sedation. Some patients are not on any continuous sedatives at this point, and some are on high doses. So we will always either turn those off or reduce the dose to the lowest effective dose to maintain comfort during this process. And then based on the patient's level of responsiveness, something called a CPOT, which sort of assesses any distress the patient might be experiencing. We also use a RASS, R-A-S-S goal, and so we assess their level of sedation. And most often, prior to taking the tube out, we'll administer a dose of morphine and sometimes Ativan at the same time or within close proximity. And then after the tube comes out, most often those medications are available every 15 minutes. So if they exhibit any distress, if those scores that I mentioned trigger the nurse's attention or my attention, then they will receive subsequent doses of the morphine or Ativan.
And how do you use the CPOT and the RAS to determine?
So that's a little bit more of a nursing-driven. They're the ones bedside throughout this process and assessing that. But that may trigger the recognition that this patient was not grimacing and appeared comfortable, and 10 or 15 minutes later we're seeing that they are more tense, and then that would prompt the nurse to administer another dose of the morphine, and those orders are already in place.
In the dose that you give prior to extubation, do you ask the nurse or look at the chart to see what the CPOT and RAS score have been?
Yes, Yes, and typically I'm bedside to assess the patient too, to see how they're doing in real time, and also looking at what doses of medications they have received up to that point to help guide me in making that dosage decision.
And when you say you administer or you dose them, you're not the one giving them the medication?
No, I shouldn't say that. Yeah, the nurse is the one actually administering the medicine. I am putting the order in and usually talking to that nurse about the plan.
And when you say you put the order in, what do you do specifically to do that?
There's a palliative care, I think it's called a terminal vent withdrawal order set, which is fairly comprehensive, and there's other parts to it, but it includes the dosing for the morphine and Ativan. So I just simply scroll down to the dosages that I want for those medications.
And that's your current practice?
It is.
Was that your practice back between 2015 to 2019?
For the most part, I think the order set has become mandatory since 2019, I believe. But there was an order set. It's probably changed some in the interim since 2015. But I think I used the order set in some cases, but probably not all cases. Sometimes I would directly enter the morphine and Ativan. So the dosages would have been the same, but it may not have been part of an order set.
And then do you know what happens after you place the order, either via the order set or just your own individual dose? Do you know what happens then?
To some extent, it doesn't directly involve me, but a pharmacist typically verifies those orders, and they are then available for a nurse to draw up and administer.
Have you ever interacted with any of the pharmacists?
Oh, sure.
Have they ever called you after you've submitted a dose?
For palliative or?
For anything?
For anything, sure, yeah.
Have they ever questioned the amount of medication or the type?
Yes, in different cases, for instance, and I'm not talking about palliative medications, but if I put in a medication that perhaps would react with another medicine the patient is already on, they'll alert me to that, and in some cases I might say, yes, we should stop that medicine, and I appreciate them. In other cases, there might be a reason that I feel the benefits outweigh the risks, and we need to give it. But there's definite collaboration there.
Okay. So you may adjust, you may explain.
Right, but there'll be a discussion and some collaboration with them.
Okay. And you said that you make sure that there is medication every 15 minutes?
Yes.
And how is that made available to the patient?
Again, it's the orders are there, so then the nurse is able to readily draw up those medications as the patient needs them.
And when you say the order is there, could you be a little more specific?
It's in the computer. It's been approved by a pharmacist. So, and I don't know exactly, frankly, what the nurse does, but she is able to access those medications then with ease and very quickly based on the patient's needs.
Okay, let's take a lunch break at this point in time. Ladies and gentlemen, can I take 15 minutes out of your lunch and come back at 1:15? Okay? I know you all have the microwave back here. Okay? Ladies and gentlemen, remember the admonition? We'll get started at 1:15.
All right.
Just relax. You can't go anywhere yet. Have a good lunch, guys.
Thank you.
Across the street and reimburse her, just so she knows that she got a
Thank you.
Doctor, while we're on recess, okay, you can't talk about how you testify.
Okay.
So if anybody approaches you about this or that, you can answer a factual question, okay? But as it comes to what you're testifying to and the manner in which you're doing it, it's off limits.
Okay.
Do you understand that?
Yes, I do.
Okay, we'll get you back here in 1:15.
Okay, very good. Thank you.
Okay.